Here we go. Good evening, everyone. It is Tuesday, May 26th. My name's John Daw, and I am here in northeastern Pennsylvania in beautiful, actually beautiful today, Wilkes-Barre, Pennsylvania. Kind of toasty outside and a little toasty in here. Got some fans going, so if you hear some background noise, that's what it is. Here tonight again for our 9th, 10th, whatever, COVID-19 live town hall with Dr. Sanjay Udoshi, who is like 2.5 miles that way in Shavertown, Pennsylvania. Good evening, Sanjay. How are you doing?
Good evening, John. Great to see you. I'm doing well, thank you. Enjoying this warm weather, and the weekend was very pleasant as well. So thanks for doing this again with us. For those of you who are new, John and I have been doing this. This is our 9th town hall. Is it 9th? Yeah.
Numbers are hard. I don't even know what day it is most of the time.
And so we are bringing information to you that is of interest and of value to the public. Every week we do a review of items in the news and then open it up for conversation. The best of the ones that we've done so far have been the ones where you feel free to just jump in and ask questions as we bring up the topics of the day. And we really appreciate all of you guys joining. We have our regulars, the ones that we love seeing their faces every time, Karen, Terry, and others here. And so let's start. John, I think what we'll do, like we always do, is go over some of the numbers, some of the information that we've gotten. We use the Johns Hopkins tracker to keep abreast of confirmed cases as well as the case fatality rate. And so again, for those of you who are joining us for the first time, the reason we cover this is to just get an understanding of how far we have come into this into this pandemic as a country and how we compare to the rest of the world. Over the last 8 weeks, it became clear that the United States has been the most affected nation in the world. We are now well over 1.6 million confirmed cases. And we have crossed the 100,000 person case fatality mark. And these numbers, when we started 8 weeks ago or 10 weeks ago, the numbers for me don't change in terms of their impact. I feel horrible every time I see that, how many people have succumbed to this disease, not just in the United States, but all over the world. So, and we'll get into a little bit about some definitions and why we call this a pandemic, a global pandemic versus an epidemic or an outbreak. And then what happens to certain diseases when we're able to either accept that they are now endemic and we have to fight them every year, like the flu, and what kinds of diseases we actually have been able to eradicate or control and contain to minimize their impact on our societies. And where we are in this fight right now against this pandemic, and where I think we should discuss about where we want to be and how we might be able to get there in the next 6 months, 18 months, 3 years, and even beyond that. So as you can see, John, if you want to zoom into the United States, and our daily case curve is in decline. However, when we compare this daily case curve to other countries, you will notice something very important here. Since March 20, what is it, about March 28th, our case count has not fallen below 20,000 cases per day. We're about to, and I hope we do this week, but that is such a significant number because, again, these are numbers on a graph, but they're actually human beings with families and friends, and they had, many of them, very productive lives. They contributed hugely to the society and the economy. And every time you see that number, 20,000 positive cases, you must remember that that means 300 people will die. This disease will take 1.5% of all the people that that test positive for it. It will take their lives. So that's why John and I are trying to educate everyone to try and keep you safe, keep your communities and families safe, employ the right strategies, because we can beat it. We can control it with our behaviors. While the scientific community struggles and fights on a 24/7 basis to learn how to treat it and learn how to vaccinate against it, and all of those things that take time. But in what we can do on a daily basis is protect ourselves and our loved ones and our friends and our community. So that's the whole purpose of this town hall, and we welcome all of your questions in that regard. So let's see. Well, we have some reporting that we crossed 100,000 deaths, but apparently Johns Hopkins is reporting that at least we have not gotten there yet. And I don't want us to get there. But as I said, it is unfortunately a truth that we have learned over the last 2 months, that this will take the lives of, the mortality rate is 1.5%. So that is not something that we want to see this. We don't want to see this climb any further. So John was bringing up the curve on Italy, and Italy is a success story that I hope we can try to follow now. Italy lost control very early and had huge case numbers that overwhelmed its health system, especially in the north and also portions of the south. Those regions started to report that they didn't have enough ventilators, as you may remember, that patients weren't able to find or accommodation in hospitals, and as a result, they had a very, very high mortality rate in the beginning of this spreading throughout their country. And then obviously there was advances and protocols that started to work for them. And they were able to, those protocols were not just in hospital treatment for these patients, which has reduced the mortality significantly, but also shutting down their specific regions where they had very, very high caseloads, turning their attention to containment as well as mitigation. So you can see now their success story is beginning. We can see that their case count has dropped to less than 1,000 per day most recently, and they're hoping to get to less than 300 a day within the next, within the next 7 to 10 days. Okay, any questions so far?
Sanjay, Lauren Roberts has a question. She's noticed that Saturday, Sunday, she's seen decreased reporting. Yeah. And then she notices spikes Tuesdays and Wednesdays. Mm-hmm. Is there any reason why
Yeah.
that might be happening?
Yeah, it's staffing. It's happening all over the world. You'll see every country has that. It is collection, and then the collection then has to the logistics of collection, and then going to the lab, the staff required to process those tests, and then the reporting. So that's pretty much a 3-day process. So we're getting to a point where we have a 2-day turnaround. So the curve will have less of this, but for the past 8 weeks, it's very clear that the weekends have that the reporting on the weekend reflects the 3 days prior, and so they just haven't gotten enough of the reporting out. And then 3 days after the weekend, in the Tuesday, Wednesday region, the backlog gets pushed out. So then you see the spikes. Okay. Memorial Day weekend. Oh, brother. So we'll have to see what this does, because there was a lot of people gathering with each other, and even in my neighborhood, which has not been affected at all. So we have no case reports in this region, this part. We had 2 in Dallas, which is next door. How long? So let me get to that. These questions are coming at me. Sorry. So we had a lot of cars in the street. We had a lot of people that are not from this neighborhood coming to visit friends, family in this neighborhood, and that's all fine and good. It's more than likely that in the last 6 to 8 weeks they haven't been sick. But what we're learning is even people who haven't been sick could be carrying the virus. They may never get sick. About 30%, 20 to 30% of the people who are so-called asymptomatic carriers, that's why we've asked people to use masks and all this other stuff in public. But to go up the street and down the street with the dogs and see a neighbor who usually has 2 cars in their driveway all of a sudden have 7 or 8, and knowing that this is happening all throughout the country, I would not doubt that we see a pickup in the case reports, positive cases in the next 10 days. It's just, it is the nature of the virus. We're seeing it throughout the entire world, that this is happening. So, and the follow-up, because it's important, I don't want to, run past some of these questions. How long before Italy, how long before the United States was Italy affected? It was I would say 4 to 5 weeks. So there was a 4 to 5 week lag in what happened to Italy compared to what happened in the United States. But our response to the virus was regional, as was Italy's initially. So most of our the most affected regions were the Pacific Northwest in the United States, who saw that initial spike and they were quite concerned about their healthcare resources being overwhelmed. Then, of course, we discussed this in previous weeks, that the strain that was affecting the Pacific Northwest in the United States has been genomically tracked to directly come to us via China. The one that has come to the New York metropolitan area and the Northeast as a whole actually came from Europe, and may indeed have come from France specifically. So that there was lag. So Italy was first affected, then Spain, then France's numbers started to climb, then the UK, with about a week in between each of these countries. So that's how all of this kind of transpired. And as I was saying, Italy, the region that was called is called Lombardy in the north, was the one where you saw the Italian military trucks trying to deal with the overwhelmed morgues and the hospitals that couldn't create enough bed space for patients. They were just broadsided. And then what happened here in the United States was we were lucky enough, not lucky, we saw what happened. It was a bellwether. It was an alarm bell to the United States. We saw what happened in Italy, and that motivated our health authorities to, get in gear. And then you saw the mobilization and the building of the field hospitals, the getting the ventilator capacity up to what could have been necessary if we hadn't done all the other, what we call NPIs, non-pharmaceutical interventions, which are, locking down, social distancing and all of that stuff. If we had just let it run a course, then the predictions of running out of ventilators and running out of bed space would have come true. So I hope I answered that.
There is a question about the death rate, Sanjay, from Glenn. Yeah. So he's asking about the origin of the 1.5% rate that you used. Fauci guessed 1%, and the CDC in a planning scenario had 0.04. And I've actually seen a lot of memes from some
I believe it's 0.4. I don't recall seeing them publish 0.04. That's absurdly low. But if it is is it 0.04?
No, it's 0.4. Sorry, there's an extra zero.
Okay. Hi, Glenn. Thanks for joining us.
Oh, it's less than 1%, which seems in itself just absurd.
Yeah. So the reason I'm using 1.5% is because that is, let's be very correct. That is not a case fatality rate. That is a mortality rate. The patients that have been admitted to hospital with the positive COVID diagnosis, either via a positive, RT-PCR, or they had the pathognomic signs and symptoms, on X-ray, fever, etc. And as well as, so it's very, the picture of what is a hospital admission that resulted in a fatality is what we use as mortality, okay? So it's not case fatality. The case fatality rate, if you were to just look at the numbers we just saw from Johns Hopkins of a numerator of 98,000 persons to have died as a result of the pandemic in the United States. However you want to assign that that blame, and that's debatable. Again, last week we talked about whether it's a 10% error. That's still a massive number. That's still 90,000 deaths. Okay, let's just use 90,000 deaths over 1.6 million positives. Then we're looking at a case fatality rate in the range of 6%. Okay, so I'm not using the number of 6% because there could be very significant error as a result of the validity of the testing. The numerator could be wrong, the denominator could be wrong, the data collection could be either over-reported or under-reported. I just take the numbers as they are and I look at it and I do the division in my head and it's 6%. But
Odie, no. What's he eating? Is he trying to get the corn?
But if you look at the mortality rate as reported by hospital, it's 1.5%. Jenny? Okay, we have John, are we okay?
Yep.
Okay.
Let's take a look at, let's see here. Those of you who know me know that I play a lot of board games and have worked in board gaming the last few years. I'm going to throw on the screen here. This is one of my favorite games. This is the pandemic game. And we see over here, we have infection rates that change. We have outbreaks. The game is called Pandemic. We have our epidemic cards here. So this seems like a perfect way to ask you the question, what is an outbreak, a pandemic? We've heard epidemic, we've heard endemic,
Sure.
whatever,
Yeah.
all these words. What
Okay.
does it mean?
So good question. So let's start with an outbreak. Okay. The typical outbreak scenario is something that you heard about I think 5 years ago with Ebola. Okay. Ebola is a infectious agent that is normally contained to, it's a what we call a zoonosis. It came over from animals, and it causes a severe hemorrhagic fever, and it rapidly kills its victims. And so when we see a cluster, which is the first group of patients that get it and then potentially die from it, and Ebola has a case fatality rate in the 60%. And there are others that are even more deadly, like Marburg. That's an outbreak. Okay, that's something that it kills quickly, and because it kills so quickly, it doesn't spread fast. Okay, so that's the important thing to remember. Outbreaks tend not to they kill so fast that they don't infect a huge number of people in a short period of time. So that's an outbreak. Okay. What happens is you get sick, and because it's so debilitating, you're not walking around others and infecting them. You're at home and sick. An epidemic will come about in a slightly different way. And what happens with an epidemic is it may be a novel agent, like we saw with MERS or SARS. And the line between epidemic and pandemic really has to do with geography, right? A pandemic is affecting a regional geography or global geography. An epidemic generally affects a nation or a group of, just a cluster in an area. So the first SARS epidemic, the first SARS, which is, sudden acute respiratory syndrome, I think it was back in 2012, or maybe earlier than that, maybe 2004, I think. And then MERS was 2012. Those were epidemics. So they affected regionally. They were spread farther than an outbreak would spread. And they followed a curve of infectivity and declination. And that was that. An endemic, and there are lots of reasons as to why a disease would become, scary fast and then go away. And that's kind of an epidemic model. And but let me just finish with pandemic. And a pandemic is what you see right now. A pandemic is what you saw with the Spanish flu. Okay, it traveled across geographies and it lingered, and it's very hard to control across vast geographies. It is it affects a continent or two continents, or in our case, 193 countries are now affected by SARS-CoV-2, otherwise known as the agent that causes COVID-19. And it has consumed the world in geography in 6 months. So that's a pandemic.
How about endemic?
Oh, okay, so endemic is something that, there's two types of endemics, okay? It affects a large number of people, and you can't easily get rid of it from a population, okay? So some people would like to would even use chronic diseases as being endemic. So you know, heart disease due to metabolic disorders, metabolic syndrome, obesity, diabetes. You know, these are chronic conditions that are endemic to American society. You know, it's something that you'll just see every day. It affects a lot of people and it doesn't go away. It may have seasonality like the flu. The flu is a seasonal endemic disease, or it may have no seasonality. It may be a you know, chronic disease that affects millions of people, like type 2 diabetes. So that's something that's endemic. Okay. I have a question for our audience. And it has to do with reporting and numbers. I was contacted by a doctor I think in Arizona or New Mexico. I don't recall exactly. And she's part of the response to COVID in her region, and is noticing a huge problem and discrepancy in the numbers. One of the reasons she's seeing that is one of the causes she's seeing that is a patient lives in a particular zip code, gets admitted to a hospital, you know, has positive for the disease, gets admitted to a hospital in a different zip code, and then so essentially may die in that hospital in a different zip code. So their death is assigned to that locality, but their actual address and where they may have been infected is completely different. And, you know, where John and I live, it's hardly, you know, like he said, we're living 3 or 4 miles away from each other. But I think, and I'm not sure exactly, I think that zip codes are pretty huge in other states, right? In like Texas, New Mexico, Utah, these zip codes are pretty vast. So it's really not giving epidemiologists a good picture of where the patients are actually getting infected, where they're getting treated, or tested, and then where they may be dying of the disease. Does anybody have any similar reporting or similar errors or anything that they've heard in their location? Terry?
Yeah, this just coming up in the last couple of days in Texas. Our county, Collin County, was doing a fantastic job, not only showing where the case popped up by a zip code, but also would show it being transferred to another one for like when they were hospitalized. And an unannounced change over the weekend is now the state does not want the counties reporting numbers. They want to take care of all the numbers themselves because, you know, some states do such a good job at it that they're, you know, and I just see us going to Florida model when it comes to counts now after that, because in Texas, they will allow no groups under 50,000 together. So that's what they're doing but they got to be at least 3.5 feet apart. So
Oh,
very safe here.
Remind me not to visit you very soon. So again, like I said, John and I are doing this for 9 weeks now, and we stay away from the politics and the political commentary. That commentary I reserve on my personal page, and that's fine. But the town hall is now increasingly having to face the fact that the epidemiology is not going to be, you know, easy to do if we don't wall off the politics. Okay, so one of the things Karen brought to my attention last week was Georgia, and I didn't really even know what she was talking about. She said there were these weird numbers that were inserted chronologically that were not, they didn't belong. They were like, you know, in May, they were inserting numbers from April, or like, it was just not properly done. And I didn't even look into it that deeply. I've been too busy with cell and molecular biology. But the thing is, if there is an agenda here to get people to feel like, okay, all the case counts are dropping, and let's just, you know, not count the deaths that are in nursing homes, and let's not work because they were not part of the general population, and therefore we shouldn't really be counting them, you know, because the general population is what we're really concerned about, these case counts going down. There may be a lag or this. They will make multiple excuses as to why they are not reporting everything that we need to know to do the epidemiology. And that's super dangerous. I don't care if you're a Democrat or who were and Democrats are being called lockdown fanatics, or if you are a Republican and Republicans are being called anti-maskers. You know, that debate is totally useless and for the purpose of what we're trying to do right now, which is just figure out, is it safe to just reintegrate our societies? Well, we need to know that based on accurate granular data, okay? I'll feel great when my neighborhood is full of cars and trucks, and I know that everybody that's in here and in the you know, Tri-County area, you know, we have 80% of the people are tested. You know what I mean? Like that granular, there's a security with that comes with knowing. If you're going to suppress knowing where the patient was living when they got sick, and then how or when they may have traveled in the last 14 days, and then where they got admitted and how they were diagnosed with COVID, and which locality they died in. If that becomes an opaque picture across the board in Texas, in Georgia, in Florida, wherever, guess what? It's dangerous for the rest of the country too, because those people travel. We saw that in Indiana. We saw that in the states that were opening early. They said, look, our bars are open. So you had 60, 80,000 people streaming over from other states, okay? So if we don't standardize how we report, and they're doing this for the reason of, let's all just get along, let's get moving again. Let's get the economy moving in. And I'm all for that. I'm 100%, I want that. But there's a right way to do that, and there's a dangerous way to do that. And I won't even use the word wrong. There's a right way to do that, a safe way, and then there's a dangerous way to do that. So,
Sanjay.
Yeah.
Oh, as long as we're talking about that, there is a question from Sandra about the CDC has the viral test results and the antibody test results combined. And I know that I saw like that the state of Vermont was doing that too. And, you know, Vermont's a very democratic state, not to blame it on politics or anything.
It's not blamed on politics. It's bad science. It's bad science. It's terrible science. And they should be totally separate. And I have extremely bad news when it comes to the antibody tests. So they're nearly useless right now, nearly useless. We had a full session with an MD PhD from India this weekend, which is published in the group right now. And we're not testing the immune response and the way to determine whether a person has protective immune, you know, has gone through the disease and has some level of protection as a result of recovering from the disease. We're not testing that the appropriate way. And I'm, again, like I've always said, I could hear that from one scientist and I will take it and then corroborate their view with 5 or 6 other scientists, which I've done, and he's right. So we, Terry, I'm sorry, man. Terry got the antibody test. Yeah, so it's not great. And we need to, again, separate it. Like, we got to have over here the detection test. The detection test has to be 95% sensitive. And we got to be, that's got to be trustworthy. Whereas the first generation of tests were about only 70% trustworthy. We'll call it trustworthy. So now we are doing the swab tests in mass. We've done about 14 million of them. Great news. We should be happy that we are testing at these levels and it's continuing to increase. And we also got a report from the CDC that says that they have a strategic testing plan. This report is about 10 weeks too late, but I'll take it. Okay, I'll take it from a scientist's perspective. Fine, we'll take it. Let's go. And we can talk about who to blame. We can talk about that the week of the election in November. But for right now, let's get our asses in gear and test everybody properly with a 95% sensitivity. Let's get that data out there. Let's make sure that those counties that are clear, okay, they have very, very low level of positive testing, can get back in gear and get their economies and small businesses back to what, being able to support their families and all that stuff. Yeah, let's do that. Absolutely. But the CDC should not have combined those tests, and I don't know who the hell was in charge that did that, because that is just totally absurd. Okay, so okay, anyone out there getting reports in your locality of not counting people who have died at home? Okay, I've heard people telling me that, reporting directly to me with evidence that police officers have been arriving at homes in their county and called by neighbors, whatever, see that the person, and then they do the back tracing and find out they were positive and all that other stuff, and it never gets reported as a COVID death. I honestly, it's an apolitical question. The non-reporting of their death is not an arguable point. I just want to know if that is a trend in the country, then we have to correct that. If we're not reporting deaths in nursing homes, we have to correct that. And it's not going, at these numbers, it's not going to affect the argument. There is no argument. We're in the midst of a pandemic. It's a nasty disease. It kills 1.5%, according to me, kills 1.5% of the people that will get it. It harms between 10 and 12% of the people who get it to such a degree that they will carry remnants of that illness with them, if not for their life, but for at least the next 4 to 6 to 8 months, it will take them to fully recover. So we don't need to argue these points. This is not worth arguing over. It's nasty. Now let's find a way to fix it so that less people die and as few people as possible get it. Because I think the first 10 weeks have taught us enough, right? Okay. All right, so segment 2. Any questions before we move on to segment 2?
Hey, can you see me?
Yes, hi.
Hi. I was just gonna say, I'm sorry, I had to allow my camera, but I'm in Nashville, Tennessee, and I was alarmed that this weekend, was it this weekend or Friday? But the difference between a week and a half ago and Friday, when they pretty much opened everything, right? That literally no one was wearing masks. It was almost like somebody just turned off or on a light switch. Whereas just a week prior, people were pretty much, if you had 100 people, 60 or 70, maybe even 75 were wearing masks. Now, if you have 100 people, it's maybe 20 or 30 are wearing masks. That's just what it seemed like. And my grown son was telling me about his job, who did have a COVID case on their floor, which is kind of like a big spread out warehouse. They're not like a meat packing plant or something that's really close, but they're close enough. And he was telling me even about a month ago that they provided them with a mask. They were trying to socially distance at the time and maybe only having a third of the people in the warehouse. But now they've really relaxed it. And, you know, my son was telling me they were really being hush hush about it, where they weren't wanting, you know, the employees to really tell about any COVID cases, talking about don't share emails, don't, you know, tell anyone, this is internal. And recently talking to him yesterday, he says there's like leads who feel like they're sick, but they don't want to go get tested. They don't want to say anything because, you know, everybody's afraid of having to be sent home and not being able to get unemployment. And then the hazard pay that they were giving, my son was telling me that, you know, they're not giving that. I'm like ready to just like be the whistleblower and have the news cameras go out there. I mean, it's really frustrating and scary. So, I mean, but I've noticed that it's just, I mean, seeing Lake of the Ozarks and other kind of places, beaches, and I'm just like, COVID is renewed, like having a great time. COVID was all up in the mix, and it's like these people just don't care. It is so frustrating. So
it's very disheartening. It can be very frustrating. I think that, and you guys can keep your video on, it's fine. In fact, I prefer it. Just make sure your mute is on, because then we get feedback. So if we see a spike in cases in the next 10 days as a result of people going out and having fun this weekend, then we again will have learned something. We will have learned that this thing is very good at hiding. Okay, it's very good at hiding, and it likes, and when it gets the opportunity to hop to another person, it will take that opportunity and it will run with it. That's why the mask thing is so important. And again, John and I live in northeastern Pennsylvania, and I have to say I'm really proud of my locals, because every time I go out, I don't see any nonsense. I don't see any people not wearing a mask, you know, any kind of protest to it. I just see people going about their business with a mask on. And more and more we've been trying to tell, John and I have been trying to tell everyone through these town halls and in other ways, that you don't have to wear a mask for 10 hours a day. You know, you just have to wear it when you're going into a store and coming out. Yay, Terry, nice one. You just have some basic precautions. And it's not, I'm surprised that Tennessee, you're seeing that in Tennessee, because that's really the wrong message, right? It's not a light switch. You know, COVID doesn't have, you know, didn't have this on their iCal that said, you know, it's over, time to recede into the darkness until some other time. No, it's out there, and we're learning a lot about how to you know, deal with it. But we need everybody to kind of understand that you got to deal with it. You can't just pretend that it's not there anymore. So as far as the business, people should be writing letters at this point. You give it 7 days and letters, if they don't work, then additional pressure has to be put on the business, because, you know, the business has to respond. It has to understand that it will not operate if, you know, 30% of its employees get sick. It's not going to be successful if it doesn't deal with this now, here and now. And the earlier you deal with it, the better. That's the evidence from across the world. You know, Japan had 850 deaths. We've got 98,000. Have you ever seen Tokyo? I mean, people live on top of each other, but they all took on the responsibility to take care of them. Groot, I'm going to kill you. They all took on the responsibility to take care of themselves and each other, and they wore masks. And they did other things. Oh my God, excuse me. I'm so sorry. Sorry. Can they go out? Go. Yeah, John gets upset with me when I don't control the dogs, but that's nothing I can do.
It's a doggy.
So yeah, so there's a way to not have this wreck us anymore. And I don't want us referring to each other as lockdown fanatics and anti-maskers. I don't want that. There's no one that I know that wants to be locked down anymore. No one. No one. No one. There are those that are irrational. There are those that are irrationally fearful, and there are those who are irrationally callous. So those are the two ends of the spectrum. We don't want that. We don't want either end of that spectrum. We want people to act carefully and take care of themselves and each other. That's it. So anyway, so the segment 2 was about this. This is a very interesting plan from the CDC. The basics are they've agreed once they go in front of Congress and Congress approves that all states will get 75% from the federal government. All the states will get 75% of their testing supplies from the federal government, which is great. So it's a turnaround from, states can take care of it themselves. We're not going to be bothered with a national testing strategy. There's actually a national testing strategy enclosed in this document, which was released today. And the numbers are a mess, but hey, we'll get there. The numbers are a bit of a mess. Anyway, so that's that. Types of tests, does everybody understand? Detection, antibody, seroprevalence. Does anybody want to cover any questions on that?
Sanders asked about information on the document. The document we will list, link to, Sanjay will link that up on the Facebook page after we are done tonight. So you can go to the CDC. And
yeah, here it is. Let me push it up, put it up here.
There we go.
Okay, that was released today.
So
a copy of it is on our group page.
Yep.
Yep.
Cool. So as we move into our next segment, it may be possible that I have watched way too much late night TV, but we are now introducing a new segment on the live stream called Told You So. Mostly because I just wanted to do the animation. So
it's beautiful, John. Beautiful.
There was no other reason except to do that for the animation. But Sanjay, maybe you want to talk about the actual content. I'm just in charge of making things look cool.
Okay. Yeah. All right. So, I got very upset when Dr. Didier Raoult, submitted the details, and this was 6-8 weeks ago. We covered this. He submitted his experiment results. It was not a study. It doesn't have a design, and we went over this a bit last week. But that was the start of this whole interest in hydroxychloroquine. A doctor in France battling COVID, overwhelmed with all of these patients that were doing very poorly, with a background in infectious disease and, having treated and tested hydroxychloroquine and other alkaloids, on these disparate types of infectious diseases, decided to give hydroxychloroquine to 36 patients. 88% of them recovered and also received azithromycin. This came across blah, blah, blah. And then there was an interest in it. And because there was the first grasp towards, okay, we might have something that could work. But it spiraled out of control. I want to cover this very quickly. We live in an era of molecular medicine, precision medicine. We don't mix things together and hope they work anymore, because we have learned how to test molecules in supercomputers and take that result and test that in a in vivo cellular model, and then tested in vitro in a living model. And then, we can do that at such an accelerated pace, something that would take 8 to 12 to 15 years in the 70s and 80s, we can do in 1 or 2 years now. And because of this precision medicine era, those of us who are familiar with these methods are skeptical when we harken back to a previous way of dealing with disease. And until you can present in our current model, in our current method, until you can present to us, clear information on where an agent is acting, how it's affecting the pathophysiologic, response, how it's affecting the pathways within the cell, which we have gotten used to having now when we develop drugs in the last 15 years. If you just say at this concentration, it might do this, I don't have time for that. I'm sorry, we don't have time for that. And we're fighting a pandemic, and that trial should take place, but it should not take place or supersede and supplant the attempts to actually use agents where we know what they're doing. Okay, we know where a particular agent is acting in the cellular pathway. We know where it's binding to what receptor and how it's, defeating a specific step in the viral replication. And the list of those agents is long. Okay, lopinavir, favipiravir, leronlimab, remdesivir, nifomostat. I mean, okay, we know where all of these things are working, but then to go and buy 29 million pills of something that you don't know whether it works or not, based on an experiment done by a guy in France on 36 patients, it's frustrating. It's very frustrating.
I have a question about this.
Yeah.
So it has been given the patients that have lupus.
Yes,
From
correct.
what I understand. So I've seen this debate where people have talked about that it should only be administered in the hospital, and then I've seen people counter, oh well, people that have lupus are taking it on their own. So I just wanted you to clarify what's going on there.
Yeah, I mean, okay, at the level of the cell membrane, we know that it has a stabilizing effect on certain cells in the immune system, mast cells and things that in lupus and in certain autoimmune diseases are dysregulated. So when you give a specific dose of hydroxychloroquine, it was discovered that it stabilizes that cell membrane and it slows down the course of disease in those patients, and they can take it lifelong, at that dosage with very little detrimental effect. Now, when you need to go from that dosage to an order of magnitude greater dosage in order for it to do something different in disease, like act as an ionophore for zinc, or act as whatever it was purported to do in fighting a viral syndrome, COVID as a viral syndrome, then you get its cytotoxic effects. Then at those dose levels, you start to see it harm the heart muscle. You see it start to harm the retina. You see it start to harm kidney cells. So the benefit that it may have, which we don't know that it does at all, is then outweighed by the damage that it's doing. Okay. Now at this dose level for 18 years, it will not harm you as long as you're seeing a doctor and taking it properly. Okay. At this dose level, even inside of a hospital, it could kill you suddenly, by cardiac arrest. At any dose level in between those two, if you're taking it by yourself outside the hospital, you could die. or you could lose your vision, or you could go into chronic kidney failure. So, you know, I could spend a day debating the molecular biology and the usage of this drug. I could spend more than a day. But the simple answer here is no, stop, please. Okay. So we've got all this other stuff that we've got to figure out, and we have limited resources and a limited amount of time to get it right. So let's go test these other drugs. I mean, I'm talking to the guys at Montefiore and Sharp and other places that are testing these monoclonal antibodies. And, you know, it's again from the anti-cancer arsenal. It's from anti-HIV arsenal. They're tested, they're ready. They've done clinical trials at the phase 3 for it to affect this receptor or this pathway. Ready to go, FDA cleared. Let's put it out there and test it on these patients and see if they get better. Because we know the risk profile. We know where it acts in the cell, okay? We've done the 11 years of work that it took to get the drug to this point. Let's test those agents. And John, I never want to talk about this again.
But I made a graphic.
It was beautiful though.
It was animated too.
Yeah, it was. It was fancy. He's getting fancy on us.
Okay, segment over. Okay. New information about testing.
Yeah.
New information, antibody testing, and mild illness.
Yeah, so like I said, I've been blessed to have friends and colleagues across the world that are doing incredible things and have incredible backgrounds. And a guy I went to med school with decided after being one of the best and brightest in our class that it wasn't challenging enough to just practice medicine. So he went and got a PhD and became a researcher, a cancer researcher. He has served at the University of Cincinnati, and now he's serving in a lab at the University of Alabama, of all places. But with his MD, PhD, and background in immunology, I held a session with him and another doctor from India. He's currently in India with his family, trying to get back to the US in the midst of all of this. And so with this deep background, he has actually done bench work, what we call, wet bench work in development of vaccines and all this other stuff. He has not great news for us. So the not great news is, and I don't call it bad news, I call it not great. The not great news is that these tests that we are using, we know why we had poor sensitivity in the first RNA detection test. We've improved that. Okay, we're doing better there. Now in the recovered patients. So we're hearing from patients that either felt like they were exposed, and they had mild illness, and it's been 4 or 6 weeks later, and they're like, I'm going to go back to work soon. Maybe I should get tested and see if I have antibodies, and then I'll feel a little bit more confident about rejoining the workforce, because what I know about having antibodies is that it will provide some amount of protection, and that protection may last between 2 or 3 years based on the strain that it'll protect me from the strain that affected the United States and my region and me. So I probably won't get sick from that again. If it is indeed prevalent in my region, remains prevalent in my region, I'll be a bit safe. Let me go get the antibody test. So they go get the antibody test, and now thousands of people are being told that they're negative for antibodies. That's problem number one. All right, we'll get back to the other problems, because there's other problems too. So problem number one is they're getting their antibody test and it's coming back negative. That's actually a problem with the test. I've just figured that out. Not me, but we have just figured that out. That the test is not testing for the full response to the full antigenic picture of the fight that your body just went through or might have gone through. So it's looking for an antibody to a particular piece of the virus, all right, which is called the paratope. So if it's only a single paratope that's predominant or that is the test that it's testing for, and you don't have an antibody against that paratope, then it's going to come back negative. But if your body won the battle by fighting the virus with another type of antibody for another paratope that was present, okay? So your body won the battle, but it didn't go after this one. It went after this one. Same virus, different piece of the virus. Then it will come back negative. It will come back negative. Only if your body won the war against the virus with this one that's in the test that it's looking for the antibody for this piece, okay? Then it will come back positive. All right. So what percentage of patients are now getting the antibody test and it's missing? The test is missing the antibodies that you do have, but it's missing. We don't know, but it's probably pretty high. It could be as high as 40%. So it could be as high as a 40% error rate on telling people that, oh, you probably weren't sick with COVID. So that's a problem. That's not great. Okay, so the second problem is recovered and you're positive for antibodies. Okay, John's putting his mask on now. There you go. See, he listens to me. I love it. So the thing is that you get it back and you're positive for antibodies. Now, are they protective or not? Okay, are they protective? Are they neutralizing? Are they protective? We need more evidence to determine whether that is true. Okay. So Lauren, they are. So there's a couple of companies at the forefront here, right? There's Roche, there's Roche, and there's Quest. And Quest was the first one out of the gate, and they thought they had a highly specific test, but now they're realizing that it's not specific enough.
And then Sandra had a question. What should it be looking for? Different paratopes?
Yeah.
All the paratopes, whatever
Okay.
they are.
Sure. Here's a picture. Okay, see all the red spikes? Okay, so see all the little yellow envelope proteins? All right, what Quest has done is it took a piece of the spike protein, and it may have taken a piece of the envelope protein and a piece of the backbone, okay? And it said, these are the 3 paratopes we're gonna test for. And if your antibodies lit up against those, that means your antibodies from your blood went into the test kit and they attached properly to these pieces, then only would it come back as positive, okay? If instead your antibodies fought this end of the spike protein and that part of the backbone and this part of the envelope protein, even if you won the war and you recovered fine and your antibodies do exist against this, it didn't light up because it didn't have the right ones in the test. Okay, so that's a problem. And then, okay, so how do we fix this problem? We got to fix the test, one, and all these companies need to stop competing with each other and start collaborating. There has to be a single reagent, a functional reagent group that they use, all of them use, and they're just they're doing the test and they make their margins on volume, okay? Not competing against any other way. So that's one thing. That's one thing. All right, so then So we understand that part, and it's coming back negative, but you actually have the antibodies. All right. What if it's coming back positive? And people are asking me, well, am I safe? Don't know. We don't know. We don't know the binding affinity of your antibodies. We don't know whether they're neutralizing. We don't know whether, because you had the European strain and somebody, you know, a student from the West Coast comes to Penn State this year and drags the virus from the West Coast with him to Penn State Wilkes-Barre or Penn State main campus, that doesn't become new in our community and starts to spread. Okay, we don't know whether your antibodies will protect against these other strains that may be coming inbound. All right, and then so that's not, but Dr. Nuthi and others in the immunology and virology community do believe that based on the fact that coronavirus 1 and coronavirus 2 have a lot of genetic similarity, 99 point whatever percent, that and the vaccines that we have done in animal models and other models have shown to be protective for 2 to 3 years, that there's enough molecular mimicry, there's enough molecular similarity that if we do successfully produce a polyvalent vaccine, or if you, let's just say it's a polyvalent vaccine, or even just the exposure to the entire antigenic picture of the virus and recovery will result in you having decent protection. Okay. All right. And then last. So people are now asking me, and I was wrong. I was wrong to suggest that people should go get, if they felt ill, and they recovered, that they should go get tested, because I didn't know all of these problems and nuances. So happy to say that I was definitely wrong here. And people were asking me now, I may have been exposed, I had mild or moderate illness, should I go get tested? And I'm telling them now, no, do not go. Sorry, Terry. Look at Terry's face. It's like, way to go, Sanjay. The good news may be, though, that Quest will offer to retest you. So I hope they do. I really hope that Roche and Quest, in a couple of weeks, say, we'll retest you for antibodies for free, because that would be the right thing to do as they improve the test specificity. So I would say until the end of June, just let them figure out what the hell is going wrong with this, because there are so many false negatives right now, too many. I mean, you have the entire course of the disease in these patients. They have had a positive nasal swab. They've had, pneumonia-like symptoms. They've had high fever, 8 to 10 days. They recover. They've got sequelae. They feel fatigued. They didn't get better for weeks afterward. This is COVID, right? We know they were hospitalized. They had it. And then they go and get their antibodies tested and it comes back negative. So we know that there's something wrong with the test. Okay, we've got a question from Carol. I'm glad you joined us. My preference is, if you do have a webcam, that you go ahead and show your face and ask the question. If you don't, that's fine, but it just makes it more engaging. So let's go to the vaccine. So where are we on vaccine development? I had a long conversation, and Karen's aware of this, a long, complex conversation about where we are and this weekend. And so what I will say is, I need to lower all of your expectations, okay? Even the best of us in the United States, I mean, we're talking about people that have done vaccine development for 2 decades. When they say it may be possible that we have a vaccine by September of 2021, that is being optimistic. Okay. Oh, great. John will do that next. So they are being extremely optimistic. September 2021. When I heard the announcement that we have a federally led Operation Warp Speed for a vaccine that could be ready by fall, how do I put this? It's absurd. It's absurd. And the reason is what they announced is the development from Moderna, that they cleared the safety qualification at the level of clinical trial phase 1. Okay. So what they did was they took the RNA from inside the virus and they purified that and they injected it into patients, and they found that the patients had no ill effect. Great. They also found that the patient's satellite cells, which are cells that are interspersed within your muscles, they're like adult stem cells. They took up the mRNA or the RNA, and they were able to produce bits of the virus. So those bits of virus then that were released by your own cells, by the patient's own cells, they elicited an antibody response because they were recognized as not being human. Okay. So all of that phase 1 work, thumbs up. Do you know how much has to happen between now and September? Because that's maybe 3 pieces of this virus encoded in mRNA, 3 pieces. That doesn't give a full antigenic picture to your immune system. So no, let me reset expectations. Moderna's RNA virus or RNA-based vaccine, do not expect it to be available or effective by September or December of this year. Okay. Now that's one method of creating a vaccine. One is to what we call the DNA or RNA vax. So you purify down the virus's genetic material, you introduce it to the body then does what it does to mimic the virus, and then the immune system picks up that mimicry and says, we know how to fight this now, let's go do it. Unfortunately, we've tried this with HIV, we've tried this with hepatitis, it works, but it doesn't work to the level necessary that the other 4 types of vaccines, effective vaccines currently work. So what are the 4 types of effective vaccines? Live attenuated, we take the virus, we get rid of its ability to infect normally, but it's still alive. Dead, okay, or deactivated virus. Recombinant subunit, which is a little bit like what I was talking about. And then toxoid, tetanus and diphtheria, and it's just the denatured toxin that we give you, and then the body builds up that immunity. There's 4 types. So what are we going to do? Are we going to eventually live attenuate coronavirus? Probably not. It's very different than influenza and others. We haven't been able to do that with HIV and other simple RNA viruses. So probably not live attenuated. Maybe a version of the dead virus, okay? That's probably the one that's going to be most effective because that's the one we use for flu. And we're able to then get all the strains in the same package, okay? So we get all the 8 strains that are currently known throughout the world. We package up their full antigenic picture, we put it in a single vial and mass produce it, and everybody gets a vaccine. That's probably the one that's going to be available to us. If we accelerate and nobody gets any sleep in the vaccine and epidemiology and molecular biology community for the next 16 months, then September of 2021 is when it will come out, and it will have cleared phase 1, phase 2, phase 3 clinical trial. Okay,
But Sanjay, then by then won't there be like 16 variants?
Yes, there will be.
Okay.
No, there'll be different strains, but right now we're containing those
strains.
strains. We're successfully containing the strains. So there may be 10, who knows? But at least the ability for us to rapidly identify them is extraordinary compared to 10 years ago. So we have the technology, we have the ability to do it, recognize them, sequence them, do the proteomics, and then build the vaccines faster than we've ever built anything before like that. So we could do that. So Dr. Nuthi thinks that it will be actually 3 years before we have a truly effective vaccine that will help us work towards eradication. Okay. Lauren, sorry. Okay, but all right. So that's about vaccines, but let's talk about really, really, really good news. Okay. Really, really, really good news is that figure that we were talking about in the beginning, 1.5% mortality. So for every 1,000 patients that show up at a hospital with a confirmatory test or set of tests, diagnostics that say that this patient is suffering from COVID, for every 1,000, we lose 15 people right now, okay? I made a prediction a few weeks ago that we will bring that down to half. We'll bring that down to 0.7 or 0.8. And I truly believe that we will do that within the month of June. And perhaps by the end of summer, the mortality will fall even further because our management of the initial portion of the disease and how it destroys the lungs, the heart, and other. So we'll be able to better manage and preclude the worst effects of the disease. And we're seeing, so forget about the vaccine for now. Can we save as many people as possible? Many more people than we were able to 6 weeks ago? Yes, absolutely. In the next 6 weeks, we will cut in half the mortality. We may be able to cut in half the morbidity. So treatment science is going to far outpace vaccine development, and that's very good news. Okay, John, go ahead. Oh, yes. We'll cover herd immunity in a moment. Yep. Okay. So here's somebody is trying to, I don't know. Anyway. So John brought up the curves. So this is not a question of economics, right? So Sweden's approach has been what Jeff brought to my attention just now is about herd immunity. Their approach is we are going to allow this disease to become endemic, and as a result of allowing it to become endemic, we assume that a large portion of our population will gain immunity. One moment, please. I'm sorry. Lily is our rescue, and she does not like fireworks. So anyway, so the model that they're utilizing is that as a result of allowing it to become endemic, which means let it spread and affect the population as it would without any non-pharmaceutical interventions, other than to isolate those that are most susceptible to the worst course of the disease, which would be the elderly and the immunocompromised. We're just going to let society proceed as it normally does, and we're going to educate those who continue to live their life with mask usage and other things that could try to reduce the speed of transmission. Not necessarily let's just call it the speed of transmission, so that we don't overwhelm our health care system. Now, this is what it looks like. So they have ever increasing counts of infections and ever increasing counts of death. If you compare them to Finland and Norway, they're direct neighbors with whom they have the most amount of trade, and other Scandinavian countries, they have 10 times the mortality rate. The bad news for Sweden is that this is not an illness like other viral syndromes and other bacterial infections like strep throat, whatever. It doesn't necessarily mean that the herd immunity being developed or the immunity being developed at the individual level is actually contributing to herd immunity. So there's some evidence, which we'll get back to when we didn't finish on testing. There's some evidence that the B cells, or the ones that actually produce the antibodies, don't even get involved in a large portion of cases. So you can recover from this and not have antibodies too. Or you can have antibodies that are non-neutralizing. Or you can have antibodies that are neutralizing and they won't show up on the tests that we have right now. So none of this not any of this is something you guys want to hear, but I'm just letting you know that this is what we've discovered. So Sweden at some point, I predict, is going to turn around and say, well, that didn't work, and start to actually put in place containment and track and trace, because it is going to get to a point where it's going to start taking highly productive lives, 30 and 40-year-olds and others that are, that they didn't think they would lose, because the initial information they got was this really is a disease that kills older people and and immunocompromised, and people who survive it fine and they get better. No. 10 to 12% of people who survive this do not get better in the 6 weeks post infection. They bring with them a lot of morbidity and sequelae. So that's not good. That means that your people that have gotten sick and they didn't die are unable to return to their productive lives and contribute to the economy because they're still not well enough. So what's the lag on that? What kind of drag is that on your economy when you can't get your people back to work? And then at what point do they decide, well, the incidence of this disease is now out of control. We have to do something to contain it. Now, on the Brazil end of things, that's a wildfire. And I don't believe any of the numbers. I think it's maybe 10 times worse than what we're seeing. Because if you've seen, I've been to Brazil, I've been to Sao Paulo, and oh my God, it's a city of 26 million people. One city of 26 million people. The population density there is astounding. The traffic, a single traffic jam can be as long, measured as long as 82 miles. Okay, that's how big Sao Paulo is. You have no idea what 26 million people living in a single province, a single city locality looks like. So those numbers are probably way off, and I think they're in trouble. So there you go. Lauren's probably crying. She turned off her video camera. She doesn't want to see anyone see her cry. So yeah, okay. What it comes down to is people have to take the people that take this seriously soon will get through this quickly. Okay, so Taiwan, New Zealand, South Korea, they took it seriously early and they're getting through it early, right? The people who don't take this seriously early will be the ones that lag and have the worst, the most damage done to their society and their economy. and other aspects. So there's that. Now let's return to the herd immunity question. I thought of a great example. If you think of a fuselage of an aircraft, right? All right. So let's load. Let's say it holds 100 people. Let's load 10 people into the back of the plane, and then load 80 people in the middle of the plane, and then 10 people in the front. The 10 people in front all have COVID. The 10 people in back do not. The 80 people in the middle have quote unquote herd immunity, and we don't know exactly what that means yet. The possibility of the disease spreading from the front of the plane to the back of the plane is nearly eliminated because the virus can't grab hold of those people in between. Okay? But that's herd immunity in the ideal circumstance where you know who's positive, who's susceptible, and who's immune. Okay? In the Sweden model, you don't know who's the seroprevalence, the testing of antibodies is so inaccurate and unreliable right now. You can't rely on that test to say that, oh, we've, in Stockholm, we've achieved 20% seroprevalence, so we're a third of the way to herd immunity. No, you're not. You don't know that. Okay? So that experiment, I believe, and my colleagues believe, is not going to end well for them. And I think that what they are hoping for is that in the time that they have now performed this experiment, the rest of the world has developed the science to cut mortality and morbidity. So they haven't lost what we lost. They haven't lost $10 trillion and allowed fear levels to rise to what they are and all that stuff. So maybe that was their advantage. Who knows? Who knows? But as far as the science behind it and the theories of epidemiology that drove them to do that, no bueno. Okay. Cindy, so basically we're screwed. We're not. It sounds bad, but we're okay. We'll be okay. If we weren't going to be okay, I'd tell you.
Hey, Sanjay.
Yeah.
Okay, so my understanding of herd immunity is we had a massive vaccination program for the childhood diseases in this country.
Yes.
That went over many years.
Yes.
And we established herd immunity for measles and chickenpox, and years to get to the percentage where herd immunity was a actual thing. So now we have COVID, and it would take years, and say 20% of our population was in anti-vax and flat earthers, you know what I mean? To get to that point now, I think we'll see a vaccine first, and that's what's going to stop it.
Yeah, no, I agree with you. It's not going to be about people getting sick and getting better, and then that conferring our society with herd immunity. No, it's keeping people from dying and people getting hurt for the next couple of years until we have a vaccine to create the herd immunity. No nation is going to develop herd immunity between now and then. No way. Mark my words. No way. There is an argument, and I don't necessarily understand it fully. You'd have to ask somebody with a background, is that, the plague took 25 or 22 or 25 human generations to develop enough herd immunity where it didn't spread to the extent that it did in the beginning of the plague. That was 400 years. Okay, throughout Europe, 400 years to develop herd immunity. But I mean, totally incomparable eras, right? Totally incomparable eras. If they had the ability to travel anyway, incomparable. Let's just not even discuss it. But yeah, herd immunity is kind of a pipe dream unless you have the vaccine and it's an effective vaccine and it produces protection for 3 to, you know, at least 3 years, at least. So, yeah.
Sanjay, is it accurate? I read something about how the fastest that we've ever produced an effective vaccine in the past with any past kind of pandemic or whatever is like 5 years. I mean, will this be the fastest
Yes.
vaccine, hopefully,
It
that we've
will.
ever developed?
It will, definitely. And it's not one team. I mean, right now I'm tracking 7 teams and all of them are taking, you know, a different methodology, and they're all sharing their information with each other. And I think they're going to be very highly successful, very fast. But September 2020, no. Let's be realistic. Okay, 9 o'clock. John wanted me to stop at this point and just totally open it up because we've actually, oh, one thing we wanted to do is a bit of a conversation around the New Zealand model of the bubble. Okay, so Karen, you go first. How many people do you have in your bubble?
In my immediate bubble is 3.
Okay.
Rob did go back to the office today, though.
Okay. And how many people does he have in his bubble? When he's outside of the house, how many people does he have in his bubble?
Well, he's actually stricter than I am. So I would say he goes to the grocery store once a week. And then his office has 5 people in it.
Okay. So grocery store visits don't count. All right.
Okay.
What counts as your bubble is people that you spend more than like, let's say you spend more than 15 minutes with and you're within 3 to 6 feet of them repetitively throughout the day. That's a bubble.
Okay. I have my partner and then my stepdaughter.
Okay. So that's your bubble. Anybody have a bubble of greater than 6 people? No. Okay. So Memorial Day, Memorial Day, the real problem with Memorial Day weekend was how readily people were able to just stick a steak knife in their bubble and rip that son of a bitch open and let anybody and everybody in. Okay. That's the problem. That is the problem. Okay. If we stuck to a bubble concept, and we may need to if I were able to convince everybody in my 25-mile radius, okay, to get tested, and then let's expand each other's bubbles in so that we have this, right? We have our big community, everybody's negative. And then we're doing track and trace as to who's coming in and out, whether they've been tested. This is the microcosm of what we have to do as a nation. And we don't have to do it at our borders, okay? We don't have to do it at our borders. We actually have to get these bubbles to coalesce from the inside out, all right? And then while we're doing the coalescing from the inside out, our borders need to be, we need to have protocols, because now I'm hearing, and I saw a bunch of people saying, well, I was trapped in Brazil for the last 2 months. I was able to get a flight back. I landed in Houston and nobody checked my temperature. Nobody asked me where I was or where I'm going. Got my passport stamped, got on a flight to DC. Nothing. How many people? Come on, man. This is not serious. As a country, if we're not doing this, we're not serious. Okay. Yeah, we've got citizens trapped abroad. They can't get flights in. But when they do come back, I mean, they have to have they have to be monitored. I've got another dog who wants to come in. Excuse me one second. What's going on? guys are driving me insane. Okay, sorry guys. So yeah, that's very unprofessional. I know, it's terrible. That's we have to be doing this at JFK, at LAX, you know, at Miami, at Chicago, Atlanta. It's a big effort. It's a big effort. But you know, Dr. Nuthi wants to get back to his university. All right. But when he gets back, I hope that they give him tracking material, you know, keep him, his kids, his wife under 14 or 21 day quarantine and make sure that they're healthy, and then they could reintegrate. Okay. And even he wants that. He wants that too, you know? So we got to take it seriously. So that's how the you know, the bubble concept works. The start with your 5, 4, 3, 4, 5, 6, whatever, and then you're able to understand that your neighbor or your family member or your friend who lives 2 miles away is adhering to the same bubble concept. You can merge your bubbles. Everybody's tested, everybody's negative. Another 2 weeks go by, you can merge with another bubble. You can get bigger and bigger over time. 6 to 8 weeks from now, that bubble could be a 20-mile radius if we take this serious. Okay.
Sanjay, I just don't see that happening. It just feels like it's so complicated for most people to actually implement. They're not going to be willing to do it. I think it's a dream. I mean, I'm in a bubble. There's 2 of us. We've been in a bubble the whole time.
Yeah.
But nobody, I mean, everybody else has other people coming in and out of their spheres.
Yeah. Well, I mean, I can't say that I'm adhering to that either. I am myself, but my children, you know, want to go and play with the kids down the street, you know, and at this point, having been strict with them for weeks and school just ending, I have to we have to start to let certain things, you know, allow us to reintegrate with our friends and our neighbors and other things.
How do you make that decision though, for, you know, how do you make that decision?
It's an extremely hard decision to make. And there are, you know, training my kids. When you come home, the first thing you do is you wash your hands, you take a hot rag to your face, all of these things, you know, so that the first thing you touch in this house isn't contaminated by the last thing you touched outside of the house. And it's just building that habit in them, you know, and even when their friends come over, you know, there's only 2 of them. They're of the same age as my boys, and they are coming in and they're being responsible. The first thing they do is wash their hands thoroughly, and then they take a hot rag to their face, and, you know, and then they're allowed to play with each other. Also knowing that there was no one who was sick in their household for the last 6 to 8 weeks, because I know their mom. Again, you know, the more you know, the better off you are. Going to a pool party in the Ozarks with 1,800 other people, dear Lord, you know. And last week I talked about how kids are wanting, you know, kids and families want to go back to the beach and go back to the pool and stuff like that. And I said, you know what, we should not be afraid of going and doing certain things, but we should be aware that we should not be crowding on the beach. We should not be standing in line for 20, 30 minutes without, you know, with people who don't have masks on to go get a hot dog. You know, I did a radio show where a woman asked, well, I felt uncomfortable because I was standing in the cereal aisle with another woman. We both had our masks on, but it just made me uncomfortable that we were so close together for that amount of time. I'm like, don't be uncomfortable. You have to understand that the duration of your exposure and the concentration of the inoculum has a lot to do with your risk level. Okay. So if you're both wearing a mask and you're passing each other in the cereal aisle, you know, bring the OCD down, just calm down. Okay. We're minimizing the threat now to others and to ourselves. We're minimizing. It's here. We're living with it. We can't get rid of it. And so we live with it. we do the smart things, and we stay safe. The smarter you are, the more you know, the safer you will be, the less risk you take on. But you're right, Carol. We cannot explain to everybody, nor can we expect them to stay away from bars for the next 10 weeks, or it's just not realistic. But we have to talk to our health authorities, our governments, whether it's the state, local, and even the federal, and lobby that, what's happening at airports right now, no way. Can't do this shit anymore. Okay, that's not a serious approach. It's not a serious response. And you will just prolong the agony for everybody unless you get serious.
Yeah, there has to be a national strategy. I mean, the optics is driving it, not the science. And that's what's so frustrating for those of us who are, complying in our bubble, trying to do everything right. And, and yet, people are coming in and out of the airports. They're not getting checked. The flights are, it's crazy. It's just crazy. Yeah. We'll never get out of it at this rate, I fear.
National guidance. So I was somewhat forgiving of the fact that we were late to respond. Now I'm less and less forgiving, because what's happening now is airline pilots are getting back on airplanes, and they're getting loaded up with hundreds of people. And these pilots and their crew are not being told how to keep themselves safe, nor are they having any standard national protocol to keep their passengers safe. Unacceptable, okay? Nurses in community hospitals continue to see shortages and in PPE, and there's no standardization on protection. Okay, so it's all coming down to their chief nursing officer looking up what's the best practices, or their quality and safety officer, disseminating pamphlets to each, and then no one's being tested as to whether they've assimilated this best practice. Nobody's using evidence. We can't do this as a country. Just can't do it.
Sanjay, Cindy, I just wanted to give Florida a shout out, because Florida is part of the Bermuda Triangle of crazy states, shared with Wisconsin and Texas, right? We're kind of always competing in the news cycle. But Cindy's reporting that Florida, has seen some beaches where they were doing social distancing, and the beach chairs were 6 feet apart.
Good, great. Outstanding. Go have fun on the beach. No, seriously, absolutely. The beach is a very unfriendly environment for the virus. It's hot, lots of sunlight, breezes, salt water. Enjoy yourself. Just stay away from people you don't know. And if you're near people you don't know, wear a mask. Okay? At this point, we can't, what else am I going to say? We have to get active in the fight, and part of that is getting out of our house. So
at this point, we are at our time for our regular broadcast, so we're going to wrap up here. Sanjay's going to stick around for as long as you want. We're going to end our live stream here. I want to thank everyone for joining us tonight. The recording of this is going to be live on our Facebook page in about 5 minutes, so you can share it with your friends and neighbors and people that need to see it. Let's see, anything else? We will be back here, same time, same place next week. Hopefully we get our webinar software fixed. That wasn't working tonight.
Yes.
But we will be back next week. We want to thank Karen for jumping in. We have gone from 12 people on these to 24 to like 30 something. So if times were different and we were all in a studio, and that would be easier, but we're not. So thank you, Karen, for jumping in there. Just a comment here that the Theme music is composed by bensound.com. And we will see you next week. And as we've said a couple times tonight, the more you know.
Yes, thank you. Thanks, John. How do I do the